One of the questions is that why is SHIF mandatory? If it's a good thing, why are we forcing every Kenyan to join? That's one question. Another question that is coming up is why should the rate be the rate of contribution be determined by the CS for health, which means that even at this 2.75%, it could be varied to any amount at any time when the CS feels like, or when she's instructed. She's also an employee of somebody. She has an appointing authority, or he that time comes. So,
this change of power.
A time may come when we wake up in the morning and we are told that it's now 5% or 10%. Nothing stops because it's set in the regulation and not in the main act by the parliament.
Now, from an IT perspective, because I've also done IT, when research was shown where these who is going to host these IT services or the management system, it's somewhere in the UK. It's not even going to be hosted in Kenya. So now Kenyans are also asking how safe is our data?
An estimated 1.1 million Kenyans fall into poverty each year. And that's because of healthcare costs. Would SHA, SHIF, UHC change that, or is there more? Or perhaps, what's the difference between a pharmacy with a blue cross and a green cross? What about cancer and the rising incidence amongst the youth? Is it just lifestyle changes, or is there more? Women's health, men's health, your children's health, the economy, this and more awaits you on season 2 of Kenya's favorite health podcast. My name is Dr. Diana Wangari-Gitau, and welcome to season 2 of the One Health Lens podcast. Welcome to the One Health Lens podcast, where we have conversations around health and related topics, making them simple and easy for you to understand. I'm your host, Dr. Diana Wangari-Gitau.
And I am Dr. Simon Moshara Kigondu.
Today we're having a heated conversation, or so I hope, around social health insurance fund, the health reforms that are happening in Kenya. We want to hear the view of, let's say, the public, people who are interacting with day-to-day common mwananchi. What are they saying? Why is there a huge uproar around, we do not want SHIF? We do not want SHIF. It's a scam and all that. That's what we'll be discussing. In studio with us, we have two very important guests. I'll let Dr. Chitayi introduce himself.
Thank you. My name is Dr. Chitayi Murabula. I'm a lecturer and a psychiatrist.
Good to have you. Kairu?
Yeah, my name is Beatrice Kairu. I'm a health economist and also a politist and also a policy shaper. It's good to be on your show.
Kairu. I mean, let me start with you, Chitayi. What's happening? I mean, there's been a lot of conversation and it seems public discourse is anti the health reforms, not even health reforms, particularly people are saying they're anti-SHIF. Why do you think that's the case? What have you been hearing? What are the questions people have? What are the questions you have?
Yeah, thank you. Thank you. By the way, I've spoken to very many people, both in my circles and even some outside my circles about SHIF. And I've also tried to understand it. One thing that comes out clear is that most people don't actually understand it very well. That is the one thing. However, I've also interacted with those who seem to understand what SHIF is, who have tried to take their time, because this SHIF came with a lot of bulky documents. There were 3 laws, and then there were regulations, and then there was the benefits package. There's a lot of information that was thrown at people. So those who have taken their time to look at it raise a lot of valid questions about SHIF. One of the questions is that why is SHIF mandatory? Section 226.1 of the Act itself says that it will be mandatory for every Kenyan, and those who do not subscribe to it or register are going to be denied government services, county, national level, and so on. So that's the first question people have. If it's a good thing, why are we forcing every Kenyan to join? That's one question. Number 2, people have a problem with the rate that is being charged. the 2.75%. For a good number of Kenyans, that those will pay as much as they were paying, or even slightly less. But a good number of working Kenyans are going to pay more than what they were paying before. And the argument that is coming out is that Kenyans already pay taxes, on their income, the income tax and other taxes. Yeah, why are they being charged? Are they being also told to pay SHIF on their gross income, having paid their taxes? That is a question that is coming out. Then why 2.75% of income without a cap? People will pay very high amounts. This is the question that people are raising. Amounts going as far as maybe 60,000 per year for someone earning 100,000. Let's say, and varying. 60,000 per year is 3 times the cost of a standard private insurance in Kenya. Another question that is coming up is why should the rate be the rate of contribution be determined by the CS for health, which means that even at this 2.75%, it could be varied to any amount at any time when the CS feels like, or when she's instructed. She's also an employee of somebody. She has an appointing authority, or he that time comes. So
this change of power.
A time may come when we wake up in the morning and we are told that it's now 5% or 10%. Nothing stops because it's set in the regulation and not in the main act by the parliament. Another question is coming up is, why should people who are unemployed pay? They are unemployed above 25 years. Why are they being told to pay? Because the point is that they don't have an income, and therefore most likely it is people who have already paid, that are going to be paying for them. You see, so many Kenyans will actually pay SHIF for so many people, especially if it is made to be as mandatory as it is. You're going to pay for your unemployed children, unemployed relatives, unemployed who and who. And then means testing. What is this means testing? Okay, we understand it's to assess the economic ability of an individual, but the question people are asking, how accurate will it be? Somebody asks that you could have built your mother house in the rural areas. You're working in a city, and then the guys who are doing means testing will go and see she has a permanent house. She's using some gas that you bought for her. She stopped using firewood. The house is permanent. They look at the roof and so on, and they determine that now
she's rich.
They place her in some band,
like the university bands for students.
And there'll be no way of getting out of it. Once they told you will appeal, but Kenya, they may appeal, but they may not get out. So the fines that are being charged, we are asking, why are these so high?
Punitive.
They're extremely punitive. It's even for employers. 2 million or 3-year imprisonment. Why are the fines super high? I mean, there was another law called the NHIF Act, which simply said that if you are late on your payment, just pay interest at the market rate. It makes a lot of sense. Or somebody who has defaulted for a year, why tell them to pay for all that period, when during that period they could not access the health care, retrospectively. But now, when they come, why don't you make it reasonable? Maybe tell them pay for 2 months, for 2 months and so on, instead of telling them to pay for a very long period. Those are the questions people are asking. And then there's also this question about the benefit itself, the benefit. So the question of benefit, I think I've looked at what almost all health specialties that have interacted with these benefits say that the benefit package is too little. And the problem is that we've never costed our health services. So it is more of guesswork. You know, somebody just sat and decided
900.
That
2000.
Yeah, that for you to be treated for diabetes, you need 4,000 a year. You know.
No, actually, they used how much they think they will get, which for me, that's also a problem. You see, so they say we will get 10,000 shillings. Therefore, for diabetes, we'll only give 10 shillings. You see, so it's not a costing problem, so to speak. It is a financing problem, meaning that they are giving benefits based on what they think they will get, both from SHA and
the people
national.
who think is the healthcare provider. And you see, that's where the problem was with NHIF, whereby there was the purchaser capture, whereby in actual sense, when it comes to insurance, the insurer should do the costing and the actual analysis. So as to say, this is going to be dental services should be 50,000. So meaning for you to arrive to the 50,000, someone has done a cost analysis, someone has done an actuarist has actually determined that price. But when right now even this shift that is being brought has already been captured by healthcare providers, and more so those in the private sector, not actually even the providers in the public sector. So they come and determine and say, for us, you know these are businessmen. They will sit and say, how do I make money from 1 million Kenyans? So they say, if I charge just 900 bob, me, I'm good, done, deal and dusted. And you see, that is very bad, because at the end of the day, I asked someone, for example, when you said CS delivery is 10,000 Kenya shillings, when you do the costing from the gloves, from the nurse who is going to the midwife, from the gynecologist who is going to attend that patient, from the lighting to the floor to the cleaner, do you think it amounts to that 10,000 Kenya shillings? I don't think so. So in essence, we are actually lying to Kenyans that they are actually going to get a healthcare system that is well reformed. But in actual sense, someone somewhere in government, and that I'm putting that as my own opinion, has decided one way to generate revenue for himself and his cronies is actually hiding behind professionalism and stating that 2.75, he has already done the maths. It's going to maybe bring around 148 billion Kenya shillings. From these 148 billion shillings, now you decide I'm going to give 104 billion shillings to Andani with his cronies, because once and for all, we know for sure the procurement process, even for determining the system that is actually going to register these Kenyans, was not open and transparent. And that is why Kenyans are feeling they're being actually shortchanged, because if it's not transparent, even the procurement of these companies that are going to actually bring in the software or the IT systems, then it means the government is up to no good. So already by that essence, there is a lot of what is it called? The community acceptance or the social acceptance of these new health reforms is very low. And that is why Kenyans are even struggling actually going to register for this thing. And the government is actually going to have it rough. So what Kenyans are asking, show us what was the procurement procedures that was actually put in place to actually say this company is actually going to offer IT services. Now, from an IT perspective, because I've also done IT, when research was shown where these, who is going to host these IT services or the management system, it's somewhere in the UK. It's not even going to be hosted in Kenya. So now Kenyans are also asking, how safe is our data? How private is this data? How secure is this data that we are giving this government is going to be safe? Number two, this management system that they're actually using for registration is on an open source. Who does that? Anyone can hack into it. So government, and then you have already given 104 billion to a certain guys we don't know, Indians, wherever, to come and say they're the ones going to establish this system, and they're hiding behind Safaricom. So Kenyans are already speculative against that. And with that is also, it begs to differ. If tomorrow somebody decides to sell our data, or like now we are going towards people are thinking about World War III and all those things. So bioweapons are going to be utilized. So imagine you as a Kenyans, your data is somewhere and somebody decides to finish off. No, when you think broadly, if you want to be very much speculative,
we can go far.
Yeah, we can go far. And every Kenyan, actually one of the Kenyans who was interviewed in Kitui, she said, I'm not registering because I'm not sure about the privacy of my data. So that's one end. Another Kenyan is actually coming and saying, the reason why I don't want to to register to these SHIF services is because when I walk into a public facility, I've already made my contribution, but when I go into a public facility, that service is not being provided. So what are they forced to do? They will go into a private facility, isn't it? Then the private facility, with the new SHIF, it's saying, if they have said it's 10,000 delivery fee, I have gone to Chitayi dispensary or Chitayi health center. Then I go there, I'm told the gynecologist is not around, the midwife is not around because of understaffing and all that. So maybe I'll go to Dr. Wangari's private clinic that is across, and she's also a provider included in SHIF. So it means if Dr. Wangari clinic is charging 40,000 for normal delivery, but SHIF has said is only going to give 10,000, it means me as a Kenyan, because you're already a provider under SHIF, I'm going to top up 30,000. So where are we cushioning Kenyans? One of the issues of NHIF was the harmonization of these benefits. And I saw one CS actually highlight, this is Moses Kuria, former CS, highlighting and saying that the 100,000, now she's earning 0. With that proximity is not even actually flexible. Number 3, the administrative cost of actually administering this to it surpasses even the aim of it. But when it's non-contributory, it means government has done its costing. I as a Kenyan, I have a national ID. So if I walk to a dispensary, or I walk to a Kenyatta National Hospital, or I walk to a county referral hospital, I being a Kenyan, I have an ID. So anytime a doctor treats me, my details are input, and that hospital can actually claim whatever it has consumed. And then the costing done, they can actually attend and say, these people are saying it's 50,000, but based on our costing, it's actually 40,000. So where is the 10,000 coming from? So it means when it comes to budgeting, the government is able to budget and say, County Referral Hospital of Boranga, they have the healthcare that has been consumed by Kenyans is 1 million. So when I allocate funds, I'm going to reimburse you 1 million because that's what you consumed.
Hakuna pesa.
No, but you're collecting taxes. KRA is collecting taxes.
And on administration, there's another question that arises from the provisions that have been given, that SHIF or SHA is going to outsource claims management to a private insurance company.
It's going.
It's already there. Somebody has already thought of it. I'm wondering, claims management is a core function of any insurer. Why should you outsource it with all this money you are collecting? Or you want to collect, you want to outsource it to a private insurance company. Doesn't that even open a door for corruption?
It does.
And what was the procurement process to actually say these guys are actually going to be the ones handling
they
the
haven't
claims?
done that.
No,
but the door is wide open.
No,
but the door is wide. They haven't done, but the door is wide open.
Yeah, they haven't done that. You guys are rumor mongering.
No.
The door is open. I'm saying
the door is open.
Yeah, they have not done it. Yes, but
so what in the ideal, not even ideal, right?
Yeah.
If you were to then get a listening ear, because part of this is if we get a listening ear, what would you want to see done differently, right? Moving forward, because the past has gone. Tomorrow it starts, right?
Yeah.
What do you want to see?
Let me just say something. I know Kairu wants to say a lot. Huh?
No.
So these guys of social health authority and who, by the way, we were discussing with the NHIF and whoever at that time, there were guys from NHIF and from whatever, the people who have designed this and who are the proponents, received a lot of information, a lot of comments, so many memoranda from so many Kenyans, ordinary Kenyans, patient organizations, provider organizations, healthcare professionals, even myself.
You wrote.
Seated here, I wrote a memorandum on mental health, the mental health package. When I looked at the final package, everything I said was ignored. In fact, the earlier package of SHIF was better than the last one that they brought about.
You're being punished for contributing.
So in fact, what they should just do, there's nothing I can add. I'll just tell them, go back to the memoranda that we submitted and incorporate our views.
Kairu, what should we do?
Number 1, SHIF should not have a role of collecting revenue.
Okay.
Because that in itself contradicts its mandate.
Okay.
So revenue collection, because collecting of premiums and contributions is solely to be given to KRA.
Okay.
Now shift to focus on strategic purchasing, so that it can also focus on the quality of care. So by the time they're onboarding this county referral hospital, they can even do the quality assessment. But when you force one to be a revenue collector, at the same time they also want to be a strategic purchaser. And remember, they have already been captured, purchaser capturing by the healthcare providers. But in ultimate, I would say this: I would rather the Kenya Kwanza government goes to tax funding for the uninsured and the poor. It is cheaper administratively, it is more effective, and it's more sustainable.
Now, two of the taxes are tax funded. Two of the funds.
But you're forcing someone first to contribute to SHIF to actually access the primary healthcare fund and the emergency chronic and critical illness fund. It beats the logic. So and that's where the issue is coming from. And that's where the issue is coming from. So I would say, don't make it mandatory. You can have two forms of schemes, for example, within. I know it had an issue with the previous NHIF, whereby now the people who are civil servants were preferred more than the people who are poor.
No, we are paying.
No, they were preferred more.
Like paying premiums.
No, we are just saying in terms of psychological, for every policy you formulate, you have to look at the social aspect. How does it impact that community? So you would find, based on the feedback from Kenyans, they would feel, who is an informal sector, in comparison to who is a civil servant, you would find most providers were preferring the civil servants in comparison to the person who was in the national scheme, who are now the informal sector. I've not even talked about the poor, the HIS program, we know how it went. So what I'm saying is that let it be tax funded for those, because they want to increase coverage. The aim is to increase coverage. Yes. When you go the mandatory way, you are telling people to repel it, and you see people are always suspicious of the government. So let it still remain the formal sector, but not the 2.75, because they have not also elaborated how they came up with the 2.75. Let it decline. Let them reduce it.
Let there be a cap.
Yeah, let there be a cap. Not just saying, tell me giving my 27,500 when I earn $1 million. Let there be a cap, but also let it the uninsured and the poor people. Don't use this proxy means that Kenyans are going to lie to you, and you won't hang me because I lied to you that I earn 10,000 Kenyan.
It's even inaccurate.
Yeah.
It will even be inaccurate.
And
some people will suffer.
And it will be very costly, extremely costly, to actually going into someone's bank account to try and determine all that.
I mean,
but when you earmark the money collected, the revenue collected, and you set aside funds and say, Kitui dispensary, actually, based on the Kenyans they served, actually, we need to be reimbursed to me. It's easy. So all we need to increase is our HMIS system. On the grass, we don't even need to take our data into UK and all that. We already had HMIS, and this data, once it is given to the SHA already, the tax funded, when it's tax funded, whereby the Kenyans who are in the informal sector can actually still be funded through that. And actually, I always ask people, how comes Mzee Jomo Kenyatta, when they set up healthcare system, were able to offer free healthcare services even when there was no social health insurance fund, quote unquote? Right? So it means it's doable. It has been done before in other countries. All we need is to remember our issues with healthcare is not because we do not have experts. It's not because we do not know what to do. But we as a country is because of the social aspect, the economic aspect, and the corruption is what ails us. And someone even asked, if you didn't address corruption in NHIF, this shift you are bringing on board, what measures have you put in place to deal with the same corruption? Or the other query most Kenyans are saying is that because there was so much fraudulent in NHIF, someone didn't want to be exposed. So the only way to deal with it is kill that initial institution and set bury it and set up. It's like they even don't want legal issues against Beatrice Kairu. I post I am dead, and I post an obituary that I am dead, and then tomorrow I take and change a name and I call myself Kalora Nyambura. So anything pertaining Beatrice Kairu is dead and buried. So it could be someone trying to hide behind reforms, and in actual sense they are burying pertinent issues that would have arose had people scrutinized the scandals that were dealing with NHIF. Last but not least, our focus over social health insurance should actually focus on the public facilities. The moment you bring private sector on board, interests are always there glaring at us. But I would wish they would really much more focus on the public facilities. They would actually really benefit from this revenue, because you see in terms of, there was a lot of allocative inefficiency with NHIF, where these private facilities were more considered in respect to the public facility. So those ones are able to buy new equipments and all that. There's no much bureaucracy at the neglect of the public sector, and yet your tax is actually being used to actually cater for that. And the other one is technical efficiency. You cannot come and demand from us to give you contributions, but on the other end, you have not even set up quality services. So you're collecting from me, but when I go, you tell me there's no service, there's no service, there's no dentist, there's no all these things. Then it means it is not goodwill. Had they come from the extent whereby they're saying, we have employed enough doctors, we have employed enough nurses, we have set laboratories, the equipment are there, everything. Actually, that would make sense to tell us to contribute. Then you see this primary healthcare fund this primary healthcare fund they're talking about, an ESCC. They actually were supposed to allocate 75 billion. It was actually let me refer. So the emergency, they were to allocate 75 billion. In the current budget, how much did they allocate? They allocated 2 billion. Then for the primary healthcare fund, they were to allocate 50 billion. In this budget that was read recently, they put 4.1 billion. Now already that shows the government is already in itself duping us. Because they should actually lead from the front. Lead from the front. Tell us they've already allocated the 50 billion. But tell us they've already allocated the 75 billion.
You're saying then we have it as tax funded, right?
Yes.
Yet the government is already saying we do not have money, and this is why we have allocated this. Where will
they
get
lose
this?
Where are they getting 104 billion to give some funny characters to actually set the...
They haven't paid.
No.
It's a
They
10-year
were
thing.
but they were allocating
No,
it.
it's a 10-year.
So,
Dana, I think another question, and another question that Kenyans are asking, and for me, I think this will be my last point.
Yes.
Is what? Why did we move from NHIF? What was so urgent? What was so bad that we had to move from NHIF when everyone thinks that NHIF was working so well? Yeah,
Was it?
Well, there were many hitches, but it was sort of starting to pick up in many ways. To be honest, even our healthcare system, you can say, it has delivered on certain level, on certain things. Even maternal mortality has gone down over the years. Our life expectancy has increased from 60, I think, in around 2 or 8 or thereabout, to right now 67 years. Things are looking up. Even child mortality has improved. So what is the justification? There seems to be no justification. My opinion is that the best way forward is, personally, I'll not register into SHIF, and personally, that's me. Personally, I'll not register into SHIF. But my advice is that we should shelf the SHIF. And the acts that have already been declared unconstitutional, null and void, as of now by the High Court. Let's go back to NHIF. Let's plan better. Let me finish my point. Let's plan better. Let's pilot this SHIF. Let's listen to the views. Let's incorporate them. Let's bring a product that is better than NHIF. And Kenyans will have no problem registering.
Yeah, and let Kenyans participate, because the way this SHIF was done, Kenyans did not give in their views.
This is going to be a campaign. It's going to
No,
be
we
a
are just putting the government to task to do what is right to Kenyans.
Fair.
And to actually don't there's a reason why Kenyans are saying it's a scam.
So we're coming back to have this conversation. Thank you for joining the One Health Lands podcast. We'll see you next time.